So our next is, we have a keynote speaker, roadmap to translating precision oncology into clinical practice. Atul Butte from University of California, unfortunately cannot be with us. He's live, right?
Yes.
Atul, are you there?
Can you guys hear me?
Hi, yes, we can hear you.
Excellent. Thank you for having me, and thanks for tolerating me being remote. I might as well just get started. I'm sitting at a Starbucks here. It's insanely early here. I think it's insanely early there too. I can see the backs of your head, and no one's drifting off to sleep yet. So thanks for paying attention. And I've been listening in for the past hour. The setup is perfect here. So I'm honored that you're having me give a keynote here. I'm just going to tell you what we've been up to at the University of California, and I hope it's relevant. I've seen the list of people in the room, so I'm really pleased to be able to present to you this morning. First, I have a bazillion conflicts of interest. There's no getting around that. Most relevant here is I'm a founder of a company called Personalis that does cancer genome sequencing for the VA hospital system. All right, so I'm going to tell you about our experience. I run this Baker Computational Health Sciences Institute. A lot of this work is coming out of this. I've been at UC now for about 3.5 years. And a lot of what we're going to show you is just in the past few years, thinking about precision medicine and especially precision oncology. As you know, at UCSF, we're in a building spree like many campuses. We literally have a precision cancer medicine building coming up, opening next year, where patients of the present and future will go to gene-based pathway clinics that we're all envisioning. Maybe it is a single gene or not, but we're all thinking this way in terms of redelivering our clinical care for precision medicine, certainly in oncology. And then we launched with this $10 million gift from Priscilla Chen and Mark Zuckerberg. So I'm going to show you what we've been spending this money on in particular. All right, so I represent the University of California, right? So we have 10 campuses. 6 of them have medical schools, 4 don't. And then we also have 3 national labs, of which 3 actually have, 2 of those are supercomputer centers, Lawrence Berkeley, Lawrence Livermore, and we also have San Diego Supercomputer Center. So we have 3 supercomputer centers, 10 campuses, 250,000 students a year, and 200,000 employees. The employees actually come up because we're probably one of the larger employers in the United States as well. And like many new academic medical centers trying to become accountable care organizations, we actually have to take care of our own. So 1/3 of our employees sign up for us for medical care, right? So they work for us, but they come to us for medical care as well. And that's a very unique set of patients, actually, where we also have to pay the bill, right? We don't just get clinical revenue. We actually pay the bill for our employees. We can go into that in the questioning. So we have 18 health professional schools, 6 of them are medical. We have veterinary schools, pharmacy schools, all the rest. We train half the medical students are residents in California, et cetera, et cetera. Most importantly, of the 5, so we have, the 6 medical schools are UCSF, UCLA, Irvine, Davis, San Diego, and Riverside. Riverside has a brand new medical school. They have a couple hundred patients. So we're going to kind of leave them out. We can't leave them out, but we're going to leave them out. So the other 5, though, have CTSAs, and all 5 have NCI Comprehensive Cancer Centers.
Atul, can I interrupt? Can I interrupt you for a second?
Go ahead.
Sorry about that.
Can you hear me okay?
If you're trying to show slides, we cannot see that. All we see is your name.
Hold on a second. You know, it helps to share your screen. Hold on. If informatics people forget that, that's a bad
Yes.
Okay, now are you seeing something?
We see your desktop. Yep. There you go.
All right. You guys put the slide up there? I can look in the video here. Yeah, that's working now, right? All right.
Yes.
So this is what I was saying before. 10 campuses, 3 national labs, 250,000 students a year, 200,000 employees. And then 5 of our medical schools have comprehensive cancer centers, 5 have CTSA programs. And, 2 of our 5 are pretty good. UCSF and UCLA are in the US News top 10, whatever that means. It only means something if we're in the list, obviously, and then we poo-poo these lists when we're not in the top 10. All right, so what we decided as a system 2 years ago, we've had years of people sharing data across the University of California and academics saying we should do more, but we now have a business reason to do this. The entire University of California has partnered with the United Health Group to make a single accountable care organization. So our aspiration in 5 to 10 years is we are going to have one giant accountable care organization. And then the minute you've decided this, you have to share all the data, right? Because you have to understand, well, UCLA takes care of colon cancer this way, UCSF does it that way. What is the UC way to do these things? So the minute we made this business decision, it was much easier to come together to share all our data. And the data I'm talking about obviously is electronic health record data. For the last few in the audience there that doesn't understand what electronic health record is, I'm sure you've seen a doctor, you've seen the backs of their head as they're typing in things into a computer. These are the electronic health record systems that physicians use and they don't particularly like, and they are extremely costly. So here are 3 examples, not to pick on anyone in that audience, of course, but Sutter is our neighbor here on the peninsula, here in the Bay Area. They've spent $8 billion on their system. Partners, Mass General Brigham, at least started with $1.2 billion for their system, and Kaiser has spent $4 billion on their system. Amazingly, they all bought the same system. They all bought Epic, as you know, so the price tag ranges between $1 billion and $4 billion for the system. And the narrative I'm trying to leave you guys with is that if we're spending billions of dollars on these systems, we are still spending rounding error close to zero using any of this expensive data, right? I call this the most expensive data in America because we're paying physicians to enter all this data in. All right, so I wouldn't be an IT guy if I didn't show a slide like this, boxes pointing to boxes. This is the concept. We have 6 campuses. All 6 are on Epic, and just to kind of be even more confusing, San Diego, Irvine, and Riverside are actually on the same instance of Epic. UCLA, UCSF, and Davis are each on their own instance of Epic, so that makes 4 instances of Epic in 6 campuses. And it's not impossible to harmonize all the data elements. We've had a system called I2B2, came out of Harvard, Zach Connie's group for a long time. We've been running I2B2 for 7 or 8 years now. So we've had the harmonization in place. We've had the IT folks talking to each other, the informatics faculty talking to each other. So that part is solvable. It's not impossible to do. Now we have a central database compared to the federated models that many others have. And there are obviously a lot of advantages to central, as we'll go into. We also have a governance and a framework for implementing this. So we now have within UC Health, so UC Health is our umbrella organization. We have IRB reliance, for example. If one campus approves an IRB, the others more or less automatically approve it. We have common contracting. And now we have this Center for Data-Driven Insights and Innovation, where we're putting electronic health record data, some limited financial data, OSHPOD, which is our state regulatory data, software tools like Vizient, benchmarks, stuff like that, claims data, as I mentioned, for our own employees and self-funded plans. And these are all the folks that we're reaching out to. And I'm only showing you this because I saw in the description, the infrastructure for setting these up is also of interest to you guys. So I'm just showing you how we're organizing things at University of California. We have UC Health, we have governance, which is critical. I'm now the chief data scientist under that governance committee. We're recruiting a health data officer, someone with an officer title. And then this is how we've set up our work. We have the infrastructure, technical infrastructure, data science, analytics. So basically the left box is Tableau. The second box is R, because you can't always buy everything with Tableau. You got to build your own. So that's with R and Python. The governance is the third box, like patients especially, making sure they understand what we're doing with data. And then the fourth is strategy and support internally and externally. Who else could actually use this data? Who should we partner with? And this has been 2 years in trying to plan and make sure people get this concept. This is, again, just for the aficionados. This is the data platform. You're going to see a lot of Tableau graphics. You can tell because of the colors, the default colors. So you'll see Tableau in a moment. Collibra is a software tool I had never heard of until a year ago. It actually is the governance for all the oncology. So each campus, obviously, we have different instances of Epic. We call different things with different symbols and different codes. And Collibra handles all of that. You can just check in and check out. You can say, we have this SNOMED code, but we're going to modify it this way. It's a very disciplined way to handle all the data munging across campuses. Wonderful tool. You buy these things. You don't need academics to write this stuff anymore. We're using OMOP, which might come up a couple times during the day today, which is an academic medical center standard. It came out of, I think, Columbia Medical School and FDA with the Sentinel project maybe 15 years ago. It's really old, but it's new again because the precision medicine, all of us programs using OMOP derivatives, PCORI, P-scanner is using OMOP derivatives. So it's open. So that means we don't have to pay Epic anything more, right? It's vendor neutral. So we love OMOP. We're building tools for OMOP. We get the download tools. We get the share tools. For SQL Server is a database. We don't need anything more sophisticated than that. I can't stand that it's not open source, but it kind of plays well with Epic. So people know SQL Server. And we're putting all this in the cloud, and we're using Azure for that because UCLA is a little bit ahead with that. All right, so what does it mean? All right, so we kind of have an unprecedented view of the entire medical system, right? So we've got UCSF, UCLA, Irvine, Davis, San Diego, and Riverside. Total number of patients with an MRN, some diagnosis data, birth date, first name, last name. We have 15 million patients. That's about 5% of the US population. And just be really clear here, these aren't claims data, right? This is electronic health records we're talking about, which is a higher resolution. Now, I know you guys are about to say, you know how noisy the EHR data is, right? I know it's noisy, but it's the legal record now, right? This is it. This is going to get in the next 5 to 10 years. We spent billions obtaining this data. It's the legal record, right? If, God forbid, one of our doctors is hit by a bus, another doctor can come in and take over the care with this record. It's good enough for that. So if another doctor can figure out what's going on with the case, we should be able to train our computers to do the same here, right? That's the kind of thinking here. So of the 15 million, we've seen 5.2 million of them recently in quotes, which means about 2012 to today. It's around when UCLA and UCSF started with Epic. Here's some rough numbers. And these change every week, basically. That's 500 million vital signs, 500 million lab tests, 500 million diagnosis codes, 250 million medication orders. We have the claims data. We've got the system pays for itself because we're doing quality and performance dashboards, which I'm not going to show you. So all of this is funded by the CEOs of the health systems. All 6 campus CEOs, the health system campuses, completely believe in this now. I don't think it's a stretch to say that. They see what we're doing in terms of improving quality of care. So we get the whole academic use for free, essentially, because we know that this is helping our health system maintain quality metrics. This is just one stupid kind of view of this thing. This is me writing SQL code. Here are 2.2 million LDL numbers across all of the millions of patients we have. This is a cardiology slide. I'm neither a cardiologist. I doubt any of you are cardiologists. But if you know your LDLs, 200 and lower is better. 200 and higher is kind of bad. And so each little tick mark there is 10,000 patients, right? So we got probably a million LDL numbers that are on the high side. Some of this is familial hypercholesterolemia. I sure hope they're on statins. Now I can tell if they're on statins, right? I can make sure that we're delivering the right care when we get these high numbers here. All right, this is just geocoding of every single patient. This is a couple months old. I forgot to update this one. This is around 4.3 million, so as of 3 months ago, just geocoding. And by the way, you do recognize that by geocoding, that means this is an identifiable database, right? Because we're using this for operations and quality control. We have the identities, right? And this is just zip code by zip code. You can see the colors represent the different campuses. And here's race, ethnicity, age, gender, basic stuff like that. Obviously, we can do. Green is UCSF, blue is UC Davis, yellow is UCLA. I guess that color is teal. I still don't know what that color is. Light blue is Irvine. Orange is UC San Diego. A little bit up between Irvine and San Diego is Riverside. They're tiny. And the yellow blob, I guess in the middle here, is Las Vegas. I don't know if you can see my mouse. Obviously, we see patients from all over the world here, not just in California. Last year, we all agreed, our 5 NCI designated cancer centers agreed that we are now going to make one giant cancer consortium. Why are we going to do this? To really get trials of the future coming to the University of California. We announced this almost exactly a year ago, and we announced one big trial with AstraZeneca. It was a combination small molecule biologic trial for head neck cancer. I don't think it was sarcoma. And so the way this worked is the entire University of California negotiated for this trial. We signed a single contract, right? We can do a single contract representing all 5 cancer centers now, and then go find the PIs. The PIs are there ready to go. And by the way, this isn't just a data set, right? We know when each patient is coming back to clinic, so we can even start to predictably model out when are these trials going to complete. When is the next patient with this particular diagnosis coming back to clinic? We can start to predict how trials are going to go. And just kind of be coy about it, here are the 141,000 cancer patients we saw in 2016, just to pick an arbitrary year. I don't know how that number compares to other medical centers, but I think it's probably pretty large. These aren't always new cases, right? These are follow-ups as well, but 141,000 cancer patients a year, roughly, we see across the University of California. All right, now obviously, like everyone else, we're getting genomic testing. We, like everyone else, send them out to Foundation Medicine, Foundation 1. UCSF has their own internal platform called UCSF 500, where about half-half, 50-50, some of our patients get the internal test for various reasons. We also do germline testing, not just cancer. We sequence different genes. So we have our own set of 500 genes we sequence end-to-end, but we also sequence to Foundation Medicine. If any of you have never seen a genomic report, this is what they look like. This is kind of obviously blanked out here. You see the variant. let's see if I can circle here. Yeah, maybe I can. You can see like the variants down here, what might be pathogenic over here. This is what it looks like from Foundation 1. You can see, variants here, especially with therapeutic implications. These are the genes and their explanations. These are kind of dense. And as one of the previous speakers said, I don't think we're truly training oncologists how to read this. We all have molecular path conferences, right? We discuss these every week. And it's still arbitrary how these get really reviewed, to be blunt. It really depends who's in the room some days, whether the right expert for each gene is there. Additional therapies, obviously trials that could make a difference for a patient. Here's a list of trials in the Foundation 1 report. And these are really, this is literally how these reports come out. They're not the easiest to parse through. You usually need committees to do this, but it's really ad hoc, I think, how many campuses are doing this. Let's see. Of course, how we get it looks like this. This is a scan fax PDF, right? We don't even get the colors unless it's an emailed PDF. Usually it comes over fax. So this is actually what it literally looks like. And you can see, I mean, it says 200 dots per inch. This is literally what a fax looks like. So I'll show you work by Ted Goldstein and Deb Datta. Deb is a HEMONC fellow here. Ted Goldstein is now a faculty member. He used to be with David Hausler at the TCGA at Santa Cruz. He's assistant professor now, but he's got a rich career as a vice president at Apple. So the guy knows how to write code. And what we can do now is we've written optical character recognition. We've tweaked open source OCR code where we can take a report like this. We can actually read it. We taught the OCR how to recognize genes and variants and mutations. And we can make a table like this for each patient, what the gene is, what the alteration that was found was. And we can do this obviously for our own reports and Foundation Medicine. Now I know you can get the raw sequences out of Foundation Medicine. We're doing that too, but this helps us go back the 2 or 3 years to quickly get all the genes that we've already found mutations for, and really to figure out what drugs might have been suggested in some of the tests here. By the way, the intent here is all of this is open source. I think some of this is already in GitHub, so you can actually download some of this code to read these reports already. All right, so this is now a pretty graphic you can make. Let me see the slide here. Let me move the window here for a second. Yeah, so this is about 1,850 patients at UCSF that had either one test or the other, our internal test or external test. It doesn't really matter. We can put it all in one database now. Sum total is about 557 genes. They're overlapping sets between the two. And it's, as you would guess, there are 150 so genes that are mutated in 10 or more samples. But I think one of the other speakers mentioned this. We have 182 genes that are mutated in only one patient, right? Only one patient has seen a mutation in one of those genes. How on earth do you know what to do with that one patient with the one gene? If the right expert is in the room, it's so random what happens right now in molecular tumor boards. So it's really, we need better tools here. Obviously, we're going to develop better tools, but we need a collective organization to do this. Now, of course, UCSF participates in Genie. I think we're the only West Coast organization in Genie. The other UC campuses aren't there yet, but of course, we're going to share and help through Genie as well. Let me see here. Hold on. Okay, so this is like cancer by cancer. Obviously, you need to know which cancer you ordered it for. That itself is a exercise because you have to parse out the clinical context in the report, right? Was it pancreatic cancer, bile duct cancer, and this is cancer by cancer. Each gene, I apologize, the colors are the same, but the gene symbols are different. That's kind of weird. Brain cancer. So obviously, P53 is the #1 gene in all 6 cancers, but TERT is in brain cancer. EGFR is in lung cancer. So we can kind of get what's already known. This just shows you that we can tell, and we can parse all this out from reports, and it really matches expectations. We plotted this versus Genie. It's almost exactly what you'd get, except for bile duct cancer. We tend to order more bile duct cancer genomes at UCSF, I think, than the rest of the entire world. We have a center of excellence there for that. So of course, now we can match this up with clinical context, right? So we have an electronic health record. It is obviously a lot of work under the hood. And by the way, we also run the death registry for the state of California. So we know every patient in California who dies and when they die, and a lot of that goes back into EPIC as well. So obviously many patients who get a genomic test result, so one of these tests lives, right? We've got 1,800 of them, 1,750 of them are still alive. But of the 50 or so that have died, this is what you're seeing on this graphic here. How many days did they actually survive with the genomic test result? On the top left is colorectal cancer, where that topmost graph, we had one patient that got the test, and then they lived 950 more days. But you can also see that there are some folks that have really only lived, there's some folks that have only really lived maybe 50 or so days here. By the way, these are negative days for pancreatic cancer. We already know that there's some patients, we order the genomic test, they're already gone by the time we even get the result back. So we got to be super careful ordering this for pancreatic cancer. You can't just use these as a Hail Mary fast, thinking, let's just do a last-ditch effort. If the patient's not going to be there in 30 days, you're not going to get the result back fast enough to actually act on it. So, we can't kind of be reckless here with the ordering here, especially if we're trying to defend this type of testing to payers. Yeah, we can't really keep doing that. So obviously, long way to go with this, right? Linking this with EHRs and trying to figure out, did we actually listen to what the report said? Did we put them in a trial? We can do that now, but Ted and Deb have a long way to go. It's all very preliminary data here that I'm showing their work here. What else can we do with clinical data? I think we can do a lot of stuff. I think obviously we're going to empower our faculty here. I apologize for this complicated slide. There's 10 bullets for the 10 campuses of University of California, right? So we're really planning to empower all of our faculty, not just the medical ones, with this kind of data. Patients should be able to download all their data in integrated record. AI researchers, obviously. I think we've already brought up machine learning. Cancer genomics researchers at Santa Cruz, obviously like a David Helsler, should be able to look at all of our cancer genomes across the whole system, and on and on. Now, of course, we're going to open this up to all the researchers in the University of California. How are we going to do this? Again, you guys wanted to know about the infrastructure. I'm just giving you a little bit of details here. On the left, so I'm making these bookends. I call these bookends. We have a fully identifiable database under lock and key on the left. And then we are creating a, quote, legally de-identified data set on the right. That means it's structured data, obviously HIPAA, 18 types of identifiers we can remove. So we got fully identified on the right, fully de-identified on the, so identified on the left, de-identified on the right. And we want that to be so de-identified, and we think we can get there, that it's going to be non-human subjects research, right? We want a certain database to be so de-identified, non-re-identifiable, that any faculty, postdoc, and student can get to it, because it's non-human subjects research, not even IRB. And then you have everything in between, which is limited data sets. If you need the dates, if you need some identifiers, if you need the genome sequence, obviously, it's not fully de-identified, it'll be somewhere in the middle, which may or may not need IRB, but it will be doable. All of this is going to be in virtual machines in the cloud, where one of our faculty signs an agreement not to share this with others and to use it, not to download data. And we'll be setting it up in Linux or Windows with R, Tableau, Jupyter, Julia, SQL, all the usual kind of stuff we use in academia and bioinformatics, plus all the bioinformatics tools, of course. And then the way we're getting this to work is each faculty will get this to work on their own local campus. It's like a UCSF faculty member will get it working on UCSF with OMOP queries. Maybe Berkeley comes across the bay to work it up at the UCSF. And then when they're ready, then they can scale across all the campuses by talking to us. So you get it to work at one campus, and then you scale it to all the campuses. Each campus now has OMOP resources. So all 5 out of 5 medical systems now, these are literally their websites where you can go and get access to OMOP. So there's something kind of beautifully wondrous when each campus has the same exact data model as the central system. Literally, I've tried this myself, SQL code that works at UCSF. It takes 10 minutes. You just move it over to the other computer, and then you can run this across the entire UC system. So that way we can scale and offer that to our faculty. Of course, the future isn't doing this beyond just ourselves. We are also working with companies in a very safe, respectful way. You have to be doing this in a safe, respectful way. Of course, things can go bad. We know all the press, right, recently. But when we do this in a safe, respectful way with de-identified data, the narrative here, though, is we cannot do all of this ourselves. We have to partner with the world's best in deep learning and machine learning. These are just some of the press releases we've had at UCSF, where we're working with GE on just X-ray detection, look at pneumothoraces and ET2 placements, work with Intel on their newest neuromorphic chips and scaling HPC. Obviously, NVIDIA sells the gaming boards, but they're useful for deep learning. And Google, in a very careful way, obviously de-identified data only, trying to predict the future for our patients. What happens the next 30 days? What happens if they get discharged? Are they going to come back, get readmitted, and all the rest? I'm going to end with one kind of concept here. This is all what we're doing ourselves. I think one of the other speakers already mentioned, the real near-term future is powering our patients. I don't know how many of you know this, but even right now, if you have an iPhone, you can go to the health app. And it's amazing, right? It's always been there, this health app, to look at your steps and heart rate and whatever, if you have one of those watches. But it also has this button here called Health Data now. If you click on Health Records in Health Data, you can click on Get Started. It's a beta, right? This is not perfect, but it does a geocode of where you are. And literally all the hospitals that have agreed, you can just click on that, sign in with your health portal. Usually your health system gives you one of these patient portals. You can sign up for that. And really all that data now is sucked into the health app. I can tell you, this is wondrous. I've seen my own father use this to get echo reports. Now, you could argue, well, who cares, right? Epic has always had an app in the iPhone. Each campus has their own app, right, on the iPhone. But the minute Apple does this, then they can really enable hundreds or thousands of developers to hit medical records. And get this, right? Any iOS developer now does not need to know who Epic or Cerner is, and doesn't even need to know who UCSF or Stanford are, right? All they need to know is what a FHIR resource looks like. They don't even need to talk to a health system anymore because Apple provides that up to any app developer. Of course, the apps have to, ask for permission. You have to give permission as an iPhone user, but that's the future. I can imagine hundreds of apps in the next 12 months helping patients navigate through their cancer care because patients will get their cancer data in this system. And that's really going to power a bunch of new app developers there. Well, let me see what I got next here. Yeah, let me thank a bunch of people. Obviously, 50 people across the UC campus working on the clinical data warehouse. It's still early days. I know you guys have folks from Flatiron there. I know curation is so much better when you pay people to do it. We're working on this. We're looking for all the experts in your room there. We're keeping our eyes on what others are doing. But at least we got our data organized in one place. It's early days. And we have system level support, right? It's amazing what you can do when the health system CEOs get what you're doing here. I have to thank a whole bunch of collaborators who helped me get all this work done, especially at UC, UCSF, Stanford, my old days at Stanford. A lot of NIH grants. Of course, we have no NIH grants to do any of this. I'm not whining, right? This is not what NIH pays for. But it's great when you can use philanthropy to get this stuff done and then health system dollars to get this work done. They truly see, I can't underestimate that enough. It's amazing when the health system sees that this actually makes a difference for them. The resources are incredible. So let me pause there, take a few questions. I know we're kind of running late. Let me take some questions and then I'll sign off at some point. Thank you.
Thank you, Atul. Next is our panel discussion. Maybe we should ask questions for Atul first. Any questions for Atul? Yes, please.
Hi, Atul.
That'd be great.
It's Ray Patrick Lake. So you probably, I haven't seen you in a while, you probably don't know that my father passed away this summer from a bile duct cancer. And what you were saying about kind of the timing of the Foundation One report and whether it's responsible to order that, I wanted to get some insight from you on what is the right time. So we had a diagnostic odyssey that lasted forever. And then I was the person that the report was complete 2 days after he passed away, revealing 5 potential clinical trials. And this precision medicine tool was never ordered early on, and we had to push for it towards the end when we couldn't figure out what exactly he had and what was the best course of treatment. So can you speak a little bit more to that balance and when you think that tool should best be used?
Yeah, absolutely. So look, first of all, I am a believer, right? I think the eventual future is we're going to get these tests really, really early in the process, okay? That's a no-brainer. It's only a matter of time. Costs are coming down, yada, yada, right? So you all get that. But right now, it is a tough time, right? Because I think we're ordering these tests, and we even have our own in academia who's doing these tests. You know who I'm talking about. But at the same time, it's our responsibility to show we are actually acting on this data, right? If we're getting these tests and not actually enrolling patients in the trials that are suggested, not changing therapy, right, then it's up to us to call it like we see it. So, or to train our own better to make use of this data. So just ordering the test doesn't do anything, right? We got to act on these tests too. And I agree. Eventually, we got to get these way earlier in the process. That's a no-brainer. But it's also our responsibility to defend to payers that we're doing something with this data, right? That's our responsibility. I take that responsibility seriously, right? That's why we're integrating all these the genomics with the EHR to see what exactly we're doing. And if we are not doing something with these results, we got to push that harder, way harder. But I think we're going to get there.
Okay. Any thoughts on how we can use this data now that the patient is deceased?
Oh, yeah. Well, okay. So not to be flippant or anything, it's super early for me in the morning here. So I tend to kind of spout up. But HIPAA kind of counts less, right, after a patient's deceased for one reason or another. I think we can really collect a lot more of this data and share what we know, what made a difference. I do think that, there are common genes, as everyone knows, and then there's a long tail of genes that are only mutated in a few. Whether those are going to make a difference or not, I'm not really sure. We have plenty of genes that have never been mutated in the UCSF patient, right? So we're learning even probably better how to run these tests. But in the end, I think there are going to be a lot of n's of ones, right? We'll have an n of 1,000 where each of the 1,000 is an n of one cancer or another cancer treated one way or another way. Look, I think we need new methodologies here. We need new statistics, biostatistics to deal with all these n's of ones. That's why you guys are all there. But I think we could start to collect, and I showed that last slide because I think patients are going to drive a lot of this too, I think, obviously. But there's only so much patients can do by themselves or in support groups or in, disease-oriented kind of groups. I think the responsibility is on the medical systems to do these too. I think the more we can share, obviously, I'm a believer in sharing, the more we can move forward together.
Can you introduce yourself? I'm sorry. For the record, I forgot.
Yes, hi. Bray Patrick Lake, Duke Clinical Research Institute.
Thank you. Yeah. Go.
Good morning. My name is Ron Klein. I'm medical officer at CMS, although this is not a CMS-based question. I was struck by your last comment about all these app developers creating cancer therapy apps for the iPhone. And I think we've learned through Facebook and through Yahoo reading our emails that what we think is free is not really free. So I would like your perception or your perspective on all these app developers and what business model they have with our cancer data, how they're going to make a profit.
Oh, I don't even think it's going to necessarily be about profit. I think it's going to be health systems developing the apps too, right? I'll just give you a really simple example. My dad had an echo and everything is fine, but I can see the entire echo report now in the health app. And just as a kind of a detail here, whether you believe them or not, right, and trust them or not, Apple says that this health data is only on the phone. It's not in their cloud. You can trust them or not, but that's what at least they say, that it's not in the cloud, it's only on the phone. And that may or may not be true. You have to trust them on that. But I'm looking at the echo myself, right? And I'm a physician, barely at this point. And this is pretty damn hard to parse. I can read ejection fraction and things like that, right? I was thinking, boy, if someone had a $4.99 app out there to help a patient understand what the hell is in this echo report, I would buy the $4.99 app today. It might be a random developer, but it might also be Cleveland Clinic selling the app, right? And so that's kind of odd, right? I can totally see a future where UCSF will have an app interpreting the data from the Brigham and Women's Hospital, right? We're going to write these apps to help patients understand them because patients are going to get this data. They can get it today. Again, whether you use that app or not, it is amazing that patients can get all that raw FHIR resource data in that app, and it's then empowering other app developers. It's early days, right? This is only as of iOS 11.5, so it's only been a year, but I think 500 health systems have signed up so far to share data because it's about patient empowerment, getting that data out of Epic, out of those proprietary portals into a vendor, you could argue a vendor-neutral system here. So I think it's early days. Look, if you don't trust, you're never going to use it, but I've seen the patient empowerment side of it too.
So can I just follow up on Ron's question? What do you see the difference between app and a patient portal? Because you can access patient portal and all your information from anywhere in the world. And it
Absolutely.
And it's maybe more secure in the long run?
I don't think it's going to work. I think, so for example, if you have a patient that gets their care, let's say at Kaiser and at Sloan Kettering, let's say, a patient has to log into 2 different patient portals right now, which is absolutely ridiculous, even if they both use Epic. Now, Epic has a central patient portal, which barely works. I don't know if you tried it. I've tried it. Barely works. I can't even get record data across 2 different campuses. So another feature right now of look, this is what is happening. This isn't future. This is present tense. If you go to the Apple app right now, you see the integrated record, whether you get at Kaiser, Sutter, Stanford, UCSF, It's one timeline. I've literally, the fasting glucoses you can chart across all of the health systems. You can't do that on a single patient portal. That's just, I'm being really blunt here. You can log into the best cancer center in the world, but you cannot see your primary care data in the same portal, right? So that's one huge difference for patients. But I'm telling you, it's about the apps, right? If a cancer center now writes an app to help parse that pathology report, that chest CT, what does that mean for me? You cannot put those apps into the patient portal that Epic sells right now. Again, they're talking about it. It's not there right now. I'm just calling it like I see it. I'm here in Silicon Valley. I can see people writing these apps to deal with health records directly. They don't even need to know what a health system is. They don't even need to know what Epic and Cerner is. They don't have to sign any agreements with Epic and Cerner. They just write their apps now. This is the new way.
Thank you. Yes.
Hi, good morning, Atul. This is Frank Wyckold from the Food and Drug Administration.
How are you?
The presentation. I'm well. I share your optimism in many ways. Yet I do have a concern, and I was wondering if that resonates with you, particularly about source data and authenticity or provenance in terms of if we open up, if we liberate health data, and if all the apps in the world will be very useful, at some point we have to be concerned about the strength of the evidence if you want to generate models to predict and also make treatment decisions and intervention decisions. How important do you think it is to work collaboratively on minimum metadata sets for clinical laboratory data and source data?
Well, look, I mean, right now, it's a great question. Right now, we do nothing, right? Patient who brings in a fax PDF to their doctor, the doctor trusts that lab test that's run somewhere else, right? They don't call anyone, they don't authenticate anything today. So remember, you got to compare it to the state of the art, which is nothing. Maybe if you go to Sloan Kettering or Dana-Farber, they'll ask for the pathology slide to reread the slide. So at least they're seeing a hunk of tissue, right? But the rest of the real world, patient brings in a lab test that their payer made them get somewhere else at a Quest or LabCorp. No one authenticates anything. It looks like a printout. So I'm less worried about that because it's at least going to be better than how we have it today. I thought the question you were going to ask is how are you going to authenticate the models for the apps? If you have 100 people making a cardiology prediction app or a cancer prediction app, how are you going to authenticate that? And where I'm going to give credit to the FDA is in the digital health initiatives, right? 7 machine learning, deep learning, even cloud-based systems now approved by FDA in the last 18 months. Clearly, FDA has shown an interest in regulating these and moving them forward and not sitting on them. So I'm giving a lot of credit to the FDA to step in to make sure these tools of the future and present are really going to be are meeting some bar, right? And making that bar as clear as possible. So I think on the app side, I don't think it can be willy-nilly that people download, Gwyneth Paltrow app that says you're free of cancer, just eat some fruit. Again, to be blunt and glib here for a second, that would be a disaster, right? But anyone could write these apps right now. So I see the FDA playing much, much more of a role. But in terms of problems with the data, we have zero today, right? A patient walks in with a fax that says I got a fasting blood sugar. The doc doesn't call to see if that test was actually run, right? We're going to be way better off than where we are now.
All right, thank you. But I think it's a question for dialogue that we need to continue.
Thank you. Are there any other questions for Atul? If not, Atul, thank you. You have any comments for us?
No, I mean, look, I'm going to look to see what you guys are doing. Obviously, I wish I could be there in person. I would totally be there, but my schedule just doesn't let me do this today. I hope this was useful. I'm easy to find on the internet if you have any other questions. I got to remove some of these slides before I share them, obviously, some of the stuff, but I'll make the slides available. And anytime you guys have questions, what we're doing, we're being very transparent about this. So let me know anytime. I'm easy to find. Thank you very much for letting me do this remotely.
Thank you.
And thanks for your attention so early in the morning. Thank you.
Thank you. Thank you. Thank you.